revise it. So
Yeah.
No, we can start now.
so these all sessions are YouTube live also. So students can have a look once if they wish to go through again. So this is the thing. So Shubham, can we go ahead?
Yeah, please
Yeah,
start.
all
Please
right.
start.
Sure. So good evening, everyone. So just a formal introduction. So we are now reaching the metastatic stomach part in this GI, decoding GI and hepatobiliary oncology. And today we have with us Dr. Chandragouda, Dr. Rushabh, Dr. Resham, Dr. Bhuvan, and Dr. Novak would be joining in a short while. So eminent faculty needs no introduction actually. So we'll be running through the similar format lecture followed by the panel discussion. So I invite Dr. Chandragouda, so who is Associate Director Medical Oncology, BLK Max, and who will be delivering a lecture on advanced gastric cancer, current insights and future prospects. So welcome you, sir. Please take over the stage and you can start with. And after that, I think Dr. Bhuvan will be taking over to moderate the session on this very topic. So please.
Thank you, Shefali. Thank you very much. I think slides are visible and I'm audible. A common question, right?
Yes, sir. Yes.
Okay.
Yeah.
Thank you.
Yeah.
So I think you've taken me back to a student stage to prepare the slides myself, and so that's worth it. Actually, it came to a lot of things, and thank you for that. So without wasting time, so I'll be proceeding, and I'll be just dividing my talk into these three roadmaps, and then probably ICPs will come in between. So HER2 negative, MSI low, HER2 positive advanced gastric cancer, and immune checkpoint inhibitors. So that they will come in between. So coming to first one, that is HER2 new negative. It's a first line unresectable metastatic disease, advanced gastric or gastroesophageal junction, and with who are HER2 new negative. So when you talk of HER2 new negative or MSI low or PD-L1 negative patients, we have these many chemotherapeutic options. So they're mainly platinum based, 5FU based, or a taxane based. So, and you have a combination of these is on the right hand panel. You can see this cisplatin 5FU, oxaliplatin 5FU, or a capecitabine with cisplatin, or a DCF, FLOT, FOLFIRI, FOLFOX. So all these regimens are there. So as a resident, we should all know which regimen to select. Is it a single agent or a double agent chemotherapy, or is it a triplet that you need to use? So for that, I think we need to know what is the evidence behind it, and what is the comorbidities, the performance status of the patients, and the age of the patient. So these are all important factors in selecting which kind of a chemotherapy that you have to use in a HER2 new subset. So we know that there is an evidence behind it, and if your patient is performance status is good enough and doesn't have a comorbidities, and he requires a response rate, we need to this is an evidence behind it. We know that there is a network meta-analysis which was done. When you have probably in doubt which one to use, we do a meta-analysis and try and see 2 versus 3 drugs versus 2 and 2, or 2 versus 1 drug. So in that, we know that using chemotherapy is definitely beneficial. All treatment of chemotherapy versus a best supportive care have resulted in supportive. So we have to use some sort of a chemotherapy. There's no doubt in the first line, as they are better than this best supportive care. So which one to use? We know that the fluoropyrimidine doublet containing oxaliplatin irinotecan, that either in the form of FOLFOX or FOLFIRI, that has resulted in significant OS benefit compared to a fluoropyrimidine plus cisplatin. So that is what is important. So either oxali with a fluoropyrimidine or irino with fluoropyrimidine is better than fluoropyrimidine with cisplatin. So that is what the evidence says. So anthracycline containing triplets or a taxane containing triplets, that is DCF, have no benefit compared to what I have just told. And the triplet containing regimens with the fluoropyrimidine, oxaliplatin, and a taxane, like we use sometimes TEF, PCF, or they're slightly better in PFS, but there's no OS benefit. So how to place this triplet over and above the platinum and fluoropyrimidine combination? So that's where you require more response rates. The disease load or the burden is more than, and the patient is fit enough, and there we can probably pitch in the triplets in a HER2 new negative or PDL negative subset. So Overall, these particular trials have resulted that yes, either you can use oxali with 5FU, iron with a 5FU, they are better and than the either triplet, be it an anthracycline definitely is inferior, be it a taxane or DCF, which is definitely increase the response rate, but there's no survival advantage. That is what, in nutshell, in HER2 negative subset, selection of chemotherapy is concerned. This is what the evidence says. So there's you can see the forest plot, the same thing which I've communicated that has been depicted in these various studies. That yes, this is what is important. We had either use fluoropyrimidine with 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 oxaliplatin or irinotecan. So to tell you that either FOLFOX or FOLFIRI are good enough compared to cis-5FU, and it is the DCF or anthracycline based combined, they're not better compared to these two drugs, except the responses. So this point, this slide, why I'm putting this slide is that when you talk of DCF as a resident days where we probably think of multiple drugs, and when you talk of DCF, you will not be able to conventionally use the doses that have been written. So in that, what this is a particular phase 2 data which says that if you dose reduce from 75 to 60 of a docetaxel or a KF study from 2000 to 1600, you can just see the response. It is half. It's almost less than half the response you achieve, which was significant. So when you reduce the dosage, the response will be reduced and hence the survival. So that is also important. When you talk of a triple combination, it may increase the response, but if you dose reduce it, the response will be half. So hence, using a doublet would be a better option. So what happens if the patient progresses in the first line, be it a FOLFOX, FOLFIRI, some may use taxanes. So we also know that the many factors, whether in actuality you need to treat them. So we have data from one of the trials saying that the performance status, the hemoglobin, CEA, metastatic sites more than 2, time to progression after the first line less than 6 months. These are all the prognostic indicators, and there are some scoring indices developed on this. So though that is not conventional or it is there. So, but this is what is important as far as the things are concerned. If there are more than 2 to 3 of these factors, so sometimes they say the best supportive care may be better than just treating them as a second or third line. So this is a standard second line therapy that have been there. Whatever you use in the first line, either it is, if you're not using taxane, this taxane results in around a survival of around 5 months. So if you see any of these agents, so it's 5 to 9 months. So docetaxel, irinotecan, ramucirumab single agent, or with the combination of Paclitaxel, ramucirumab, your rainbow study has resulted in 9.6 months of median survival, better than all others. But we have already used this drug. I'm not a fan of ramucirumab, and because we used it before it came to India, I never seen a single response with the ramucirumab. So though the data suggests that you can use with the Paclitaxel combination in the second line, resulting in some better advantage compared to other agents, but I'm a bit skeptical. I won't use it. So what if you use a fluoropyrimidine, and that's if you, for example, in the colon, if a patient progresses on FOLFOX, you use FOLFIRI, you're continuing the 5FU on. Can you do the same thing in the stomach? No, you cannot, because it is just increasing the toxicity. There's an evidence to suggest that if you continue 5FU beyond progression in advanced CS stomach, there is no advantage whatsoever. So also cisplatin. Sometimes you use when you use a cisplatin, paclitaxel or paclitaxel in the first line of a patient, there's a poor PS. So down the line, can you use the platinum again with irinotecan? There also, there is no difference in the overall survival. So adding a platinum again in the second line is not going to be beneficial. Now, what is the data of immune checkpoint inhibitors in the second line and beyond? So there is an ATTRACTION 2 trial of a nivolumab which improves overall survival versus placebo in more than third line in patients who have unselected by PD-L1. If you see this data of ATTRACTION 2, that the patients with nivolumab have median OS of 5.32 months versus 4.14 months, and also 12-month OS rate was 26% and 10% in patients in nivolumab. So an unselected population, the nivolumab is a way to go, and more so in a squamous histology and in Asian population. So in that, even in a patient who has second line, you can give a nivolumab. There is a data on that. So what about pembrolizumab? The pembrolizumab also has an efficacy, and as shown in by Keynote 061 trial, that though this is a negative trial, but if you just extrapolate or the exploratory analysis in the patients who have CPS more than 10, that there is an advantage of pembro versus paclitaxel. So hence, in a patient more than a second line and a third line, you can use pembro also in patients who are who have a CPS score of more than 10. So neither histology, more so in a squamous histology, this pembro can be used. What if a patient has HER2 positive disease? So HER2 positive gastric cancer, we have come a long way from our resident days, where we used to, this was one which came in that particular era. Yes, can you use a targeted agent in a stomach cancer? Yes, in a patient with HER2 positive stomach cancer, there is a TOGA trial which has shown an efficacy of adding trastuzumab to a 5-FU and oxali or a platinum-based combination. And also, I just want to highlight to residents that the testing of HER2 positivity is slightly different in stomach compared to breast cancer, as luminal surface of these cells are not positive. So hence it is more of a lateral surface which is more positive for the HER2 So that's where it is expressed. So that's one difference in terms of HER2 expression in stomach compared to a breast cancer. The second thing is that it is heterogeneous. We do not know which particular block is going to be positive. So at least there is a dictum in that there is a guideline saying that at least 5 should be tested. So until then, you cannot call it as negative. So this particular the guidelines, CAP guidelines, should be so everyone should be aware of, as these are slightly different from the breast cancer. Coming back to our TOGA trial, in a patient who is HER2 positive, they were pitted against the addition of trastuzumab with the chemo combo, that is 5-FU or capecitabine with cisplatin. You can see the OS is 16 versus 11.8 months at 12 months, and it is significant. So this is the first trial to show that that tested the hypothesis for adding a targeted agent in this particular scenario has resulted in a benefit. So there are other trials of adding an anti-EGFR, an anti-VEGF molecule without much benefit in patients who are HER2 positive. So what you do if a patient has progressed on HER2, that is trastuzumab. So there are various trials which I'm not going to delineate because all were negative. Lapatinib, TDM1, pertuzumab, they were all being tested, but all were negative. There is no advantage whatsoever. What was the reason? So they say that there are almost 2/3 of the patients lost the HER2 positivity after treatment with trastuzumab. They lost the HER2 positivity. Is there any drug in this era that is going to benefit? Yes, there is a trial of trastuzumab deruxtecan which has shown some benefit, and this trial has retested the HER2 positivity. And somebody who is HER2 positive, again, they were put on TDX, and there is some advantage and the good response rate that have been seen with the TDX, that's trastuzumab deruxtecan. So there is an indication if a patient has failed trastuzumab, you cannot continue trastuzumab as there's no advantage. We cannot use lapatinib, TDM1, pertuzumab as they do not have advantage. Yes, you can use a TDX if it comes to India, and they should be HER2 positive. So that's what about the HER2 positive. What else we can do in a patient who is HER2 positive as well as MSI or a PD-L1 positive? So these are the subsequent 3 trials which I'm going to elucidate in the first line, which have made a difference and which have probably the change of practice that we used to think before. So in that first one, this is a combo. This is a trastuzumab, the pembrolizumab data, that is the Keynote 811 trial in patients who are HER2 positive. Adding pembrolizumab is going to be helpful or not? That was a question asked. So HER2 positive, adding pembrolizumab. In this particular trial, you see the phase 3 randomized 264 patients were enrolled in who are advanced gastric and esophageal junction, and the adding pembrolizumab has resulted in the improved objective response rate to 74 versus 52%. Complete response for 11% versus 3%. Adding pembro resulted in 11 CRs, and proportion of patients still ongoing response at 6 months is 65% versus 53% on pembro or chemotherapy. So that is what it indicates. This in a patient who has got HER2 positive disease, frontline adding pembro definitely increases the response as well as CR rate. So this is one which is a new insight. The second in the same setup where it is HER2 negative subset is data of nivolumab. So checkmate 649. There, a combination of Nivo AP was one arm, and in the other arm it is only chemotherapy, and in the third arm it is a Nivo combination of either 3 weekly or 2 weekly with chemotherapy. So immunotherapy with chemotherapy, only chemotherapy, and combination of Nivo AP. So that was a trial which was designed. So the co-primary endpoint of PFS and OS was done, and they were secondary endpoint was like the secondary analysis depending on CPS more than 1 or more than 5. That was the schema and this thing. This is the results. If you can see the median OS, I'm just put this slide because this is what with the want of time. If you see the CPS more than 5, the median OS of a Nivo plus chemotherapy was 14.4 months versus chemotherapy, which is 11.1 months. So also the progression-free survival, the 8.1 month versus 6.1. So you can use a nivolumab in the front line if a patient has CPS score of more than 5. It's very important that we should do a CPS, not the TPS here. So in patients who have CPS more than 5, we have an option of nivolumab or pembrolizumab with a chemo combination. If a patient has a HER2 positivity, you can just add an anti-HER2 therapy with chemo, or you can add pembrolizumab to that particular arm because they all have shown an advantage. So that's what the frontline data suggests. So this concluded 649 that the addition of nivolumab to a chemotherapy in a CPS more than 5 has resulted in OS benefit of 14.4 versus 11.1 months. That was a take home from this particular trial. And this is one more frontline in a HER2 negative subset. So if you have nivolumab data, can you use a pembrolizumab single agent or pembrolizumab with chemotherapy or with just chemotherapy? So this is a Keynote 062 trial where a patient with same similar design HER2 negative disease are pitted with a CPS score of more than 1, were randomized to 3 arms: pembro chemo, or only chemotherapy. So these are the results. In a patient who has got a CPS more than 10, there is an advantage of adding a single agent pembrolizumab. At 12 months, there is a pembrolizumab has resulted in 57% versus 47, and at 24 versus 39 versus 22%. So single agent pembrolizumab is good enough in patients who have CPS more than 10, and it has resulted in a survival advantage. And all others, it is not. In others, if a patient has an MSI, so MSI high patients, the pembro is in the top, you can say the upper graph, and versus the chemotherapy. This is pembro chemo versus only chemotherapy. So both have resulted in either CPS 1 or 10. The MSI high also benefits adding pembrolizumab. There's all the exploratory analysis, though the MSI high patients in this subset were only 50 patients. So they say that in a first line setting, if a patient has CPS more than 10 or an MSI, you can use pembrolizumab single agent or pembro or chemotherapy. So how do you place it? If the patient has more of the more burden of the disease, probably you can combine chemotherapy. If a patient has less burden of disease, then you can probably use single agent pembrolizumab in a CPS more than 10 and MSI high. So that's how it is. So it did not, sometimes in some patients where the chemo combination with the pembrolizumab did not improve the survival in patients who have less CPS because of these many reasons which they have given in there. And they're coming to the last few slides of mine, where are there any new perspective? We know that we just used to treat with the chemotherapy and the anti-HER2 therapies. Now the immunotherapy has come, and with in combination with the anti-HER2 as well as chemotherapy. And now what are there any molecular subsets that how do you divide? Are some patients chemo responsive? We have already seen that some sort of a histology are chemo responsive, some are not. So in that, there are different incidents of gene alterations that are seen in different histologies. So this is the alteration, and this is the incidence that has been seen with these particular gene mutations that we see in patients with intestinal or a diffuse type of the cancer. So you can see the different mutation types of intestinal or diffuse type with these genes. So this is how it is added. What it has added is the molecular characterization revealed there are 4 different types of gastric cancer. That is EBV positive, microsatellite unstable, genomically stable, chromosomal unstable. So this was published in Nature 2014. These types are differently represented in the different parts of the stomach. And also their sensitivity to classical chemotherapy and the options for targeted agent appear to be different, which has to be now prospectively evaluated. We know that we have come to molecular subcharacterization of this cancer, CS stomach, and we have done in many other cancers. We are looking at the same lens in stomach cancer also. So hence this particular Cancer Genome Atlas Research Network, which was published in 2014, has divided them into 4 main categories, and they have a different gene expression profiling, and whether this gene expression profiling responds to different agents, and with the time will see us with the results and the further research, we'll be probably delineating this particular part of the research. I think with also the singlet links, this also has some sort of evidence of retrospective data that sequencing adenoma may not benefit from perioperative chemotherapy. So just some sort of evidence from what I have elucidated from the molecular data. I think with this, I thank Dr. Shefali and all of you for giving an opportunity and patient listening. Thank you.
Thank you so much, sir, for this wonderful talk. And I think we know that what are the regimens available, how to select that, and new advances in treatment now being immunotherapy on cards in the first line in selected group population and HER2 positive. I think this is going to make a good change in treatment of gastric cancer paradigm. So if somebody has some questions, please put in the chat box. We'll be taking as the panel discussion progresses. So I invite Dr. Bhuvan to moderate the panel discussion and invite the panelists also. Dr. Bhuvan.
Thank you, Dr. Shefali, and thank you, Chandragouda sir. I think that was a very comprehensive presentation, and I think you could nobody could have summarized it as beautiful as you did. I was thinking, how do I go about doing the way you divided the topics? I think that was the perfect way to divide. So without biomarkers, with biomarkers, and then divide the biomarkers into HER2 and non-HER2. So I think let's take the, sorry, my video is not working. So we'll just try to do it on the background. So
Bhuvan, I think Novak has some issues, so he'll not be joining. So you have Dr. Chandragouda, you have Dr. Rushabh, and you have Dr. Resham. So 3 panelists with you.
If all of you are here, and I think it's a good learning exercise which we'll have. So let me just start with presenting my slides. So moving forward, we are discussing the metastatic gastric cancer panel discussion, and we'll try to take it forward. So we had a gentleman, or we have a gentleman who's a 53-year-old gentleman, and he is a known case of type 2 diabetes. He is a fairly well-educated guy with no previous comorbidities and with the diabetes history, with the care which is being provided by the family. And there is no issues as such in terms of, financial constraints are not there. They are pretty well to do. And he is otherwise a fit gentleman. So he had presented in April 2020 with the history of, with a reduced appetite and weight loss for 2 months. And, endoscopy done had shown a lesion in the G junction, the biopsy of which was moderately differentiated adenocarcinoma. And then he underwent ancillary workup, and the organ functions were normal, and the PET scan was, the viral markers were negative and echo was normal. A PET scan which is done was shown it had it was a metastatic disease, and there was a good amount of disease, and the focus of disease actually lied in the stomach, the body and the cardia of the stomach rather than in the G junction, as that. So hence, basically a mural thickening involving G junction, fundus, cardia, body of the stomach, with the a predominant involvement of lesser curvature with the abutment of left lateral segment of the liver. And there were good amount of nodes with omental deposits, hepatic and pulmonary metastasis with the left supraclavian lymph nodes. As previously mentioned, echo was normal, and impression was metastatic adenocarcinoma stomach. So he was started on palliative therapy with the cytotoxic chemotherapy, and I think it has been the thing has been very well illustrated by Dr. Chandragouda already. Then how do you go about choosing a single drug versus two drug versus triple drug therapy, and the latest immunochemo combinations, and what additional tests are required? So if I can have my panel, if I have my panelist, and if so Chandragouda sir, as you rightly said, and could you just reinforce the point between single drug, two drug, and triple drugs, and how do we go about choosing the immunochemo combination? We will come to the additional test and the specific therapy in a minute, but in one sentence, a concise message to all those who are listening. How do you go about choosing the number of drugs?
As I was telling you, two drugs are good enough. That is either 5-FU with irinotecan, 5-FU with oxaliplatin. So these are good enough. And how do you select triple drug? Adding a taxane or an anthracycline based chemotherapy. Anthracycline definitely is out of the way because that is more toxic, doesn't result in anything else. DCF, like taxane based treatment, it has resulted in more response rate. There is no survival advantage attached compared to only two agents. So given a choice, 5-FU irinotecan or 5-FU oxali is a standard of care now.
So as I hear it, loud and clear, the two drugs is a way to go. There is no additional benefit of adding a third drug unless you are, unless your aim is to have a better response rate. There is no otherwise overall survival benefit.
Correct.
In terms of, what additional test? If I can ask my other panelists, what additional test would you recommend in such a patient who has had there's a CS stomach, and what additional tests? So I think Dr. Rushabh is there. Dr. Rushabh, if you could help us identify what other biomarker tests would you identify?
So the ones mentioned, HER2 by IHC, if needed FISH, MSI by IHC, and PDL1 by IHC. This is what I do at this point of time. I'm not doing TMB for everyone. I'm doing HER2, MSI, and PDL1 at this point of time.
So I think what you say is and the problem with PDL1 or TMB is that it'll require a separate comprehensive genomic profiling. So Dr. Resham, do you agree with us, or do you differ with any of us? Dr. Resham?
Dr. Rushabh, I think you can unmute yourself. Shayad mute ho aap to nahi abhi.
I think Rushabh is there. Rushabh had answered already.
I already answered.
So Dr. Resham se baat. Anyways,
okay.
So the thing is, additional tests obviously are done, and the patient was a HER2 positive disease, and it was a MSI intact and a PDL1 5% with a CPS on a DACO-22C3 platform. Now, coming back to Dr. Chandragouda sir, in such a patient, as we all understand, dual drug. So, is there any way you would add a triple drug with a trastuzumab? Dr. Chandragouda?
Yeah. So it's HER2 new positive in extensive disease. We know that yes, adding trastuzumab definitely benefits in the first line. So I would definitely oxali, maybe a toga kind of a thing, a 5-FU oxali, because there the cisplatin was used. So it's a 5-FU cisplatin with trastuzumab. Now probably adding pembrolizumab might be beneficial in this particular. So we have seen the data, and that we need to just wait for till it matured. So I think adding pembrolizumab in this particular subset also benefits. Yes.
I think that's a fair point. So Dr. Rushabh, you heard the keynote 811 data. And do you agree that would you jump the gun and add pembro to the already cisplatin 5-FU with trastuzumab? Does it? So it's academic discussion, but then you can't keep the finance out of it. So cisplatin 5-FU trastuzumab plus Perjeta plus Keytruda, does it? Is the data strong enough for you to add that drug there, or you would still want to be a little cautious?
So as of now, I have not started using IO in first line in HER2 positive subset. Data looks exciting, but I don't have any first-hand experience. I generally do doublet with trastuzumab currently, but data looks exciting. Means if finances is not an issue, which is going to have a difficult task because pembro plus trastu plus doublet, is not going to be a cost-effective regimen. So if finance is absolutely not an issue, I would try to give 4 drugs, means Pembro, IO plus trastuzumab plus doublet upfront.
Dr. Chandragouda, what was the benefit? If you could just highlight the benefit of adding Pembro to the HER2. Could you just?
One is the response rate. So
Okay.
we have a response of almost 70% versus 50%.
Yeah, I think there's a 20% increase in.
Yeah, it's huge in a patient who has got extensive CA stomach. That's one thing. So over and above Trastuz and chemo, definitely there's 20% extra response rate. And at around more than 6 months of a follow-up, 65% of the patients are still continuing this particular treatment compared to only around 40% or so. So there's some advantage of adding definitely a Pembro, but we have to wait for final analysis. So it's still definitely an interim, and it is definitely an exciting.
I think the only point which bothers me a little is the duration of response, which was around 10 and a half months with Pembro, addition of Pembro, and without Pembro it was, I think, 9.5 months.
Yeah.
I think that's a little offish if you look at it. Yes, it does improve the response rate by 20% or odd, but
Correct.
if the duration of response has not improved, I think so once you're doing a double drug with trastuzumab, you already expect a response rate for around as rightly said, around 50 to 60%.
Correct.
And adding, but if it doesn't add to a duration of response, is it good enough, not good enough? I think as you rightly said, the data has to mature to give us anything which is and as we all understand, adding IO in the first line, it's not about the duration of response in the first line, it's eventually the response later in the later lines, which obviously gives by the addition of IO in the first lines.
Correct.
So I think that's rightly.
Yeah, one more thing which I just want to add, Bhuvan, is that these upper GI cancers are very bad. So in that context, whatever we get, some sort of an extra benefit, and some patients may end up in some sort of a cure or a long-term survival. So we probably buy it. So I know definitely it's too early to say, but still, it's in this particular bad disease. It's still this data is looks exciting.
Fair. So moving forward, the patient was started on DCF trastuzumab. He was started on DCF possibly because he was a performance status 0 patient. He took 6 cycles followed by interim response assessment. It was a significant response to therapy. He was continued on DCF based regimen with and plus trastuzumab for the 6 cycles. At the end of 12 cycles, the patient had even had a further response with a further reduction in hepatic metastasis. And then he was continued on trastuzumab maintenance from October 2020 to February 2021. And so I think this is what a little it was a little if you look at the patient was started on April 2020, and it is exactly 10 months that the patient had progressed. So I think all those who feel that the data doesn't come into the clinical picture, I think this is exactly how it comes to the clinical picture. And I think in March 2021 there were new lesions in the brain. There was a hypermetabolic lesion in the right cerebellum with associated parenchymal edema, along with other lesion in the left cerebellum. An interval increase in the metabolic activity. There was a mixed degree of response in the systemic, but there was a definite progression in the brain. Contrast enhanced brain was done, and it revealed hemorrhagic lesion in the each cerebral hemisphere, right sided, which was larger than the left sided. So if I can have my radiation oncology colleague, Dr. Resham.
Hello, am I audible?
There's a lot of echo. If you could,
Dr. Resham, probably you are logged in through 2 devices, so it is echoing. 1 minute. Hello?
Yeah, now you're audible and well.
Yeah.
So
Hello.
I think possibly you will be the best person to tell us how do you look at the hemorrhagic lesions versus a non-hemorrhagic lesion? Is there something different in the terms of pathology prognosis, or is it same?
Yeah, hemorrhagic lesions are more aggressive rather than non-hemorrhagic lesions.
Okay. And what other cancers do you prefer, but would you generally tend to find a hemorrhagic lesion versus a non-hemorrhagic lesion?
Yeah, so it's basically, if you see RCC and this GI and melanoma, we find hemorrhagic. Versus breast, in breast, we generally see non-hemorrhagic lesions.
Okay, and is there a difference between the supratentorial and infratentorial lesions? The supratentorial are generally non-hemorrhagic, infratentorial are hemorrhagic. Is there any difference like that? Has it been studied?
For that, I actually don't have any idea.
Fair enough. So what you said is, as you rightly said, the vascular tumors, which is RCC, is a vascular tumor, melanoma just has a vascularity, and then stomach is what you find. You said you find a hemorrhagic lesion. So is there a difference between the way you treat a hemorrhagic brain metastasis versus non-hemorrhagic brain metastasis?
See, in this particular patient, because it's hemorrhagic and there are lots of edema. So if there is lots of edema and patient is neurologically symptomatic, so we would prefer to go for surgery rather than going for SRS or SRT at first go.
Okay, and that's interesting, and that's something which that's totally unlike radiation oncologist. But then, sorry for saying that. And so fair enough. The patient had a bilateral cerebral lesion, and if the patient, and it's an infratentorial lesion, and as you rightly said, that if there is a if there is a impending herniation is what you mean, I think. If there is an impending herniation with the infratentorial lesion,
as well as edema,
that's the reason you probably would end up preferring a surgery over a radiation. But then,
yes,
is it does it matter that he has he has developed a bilateral lesion versus a unilateral lesion? Does it change because if it requires a surgery, it will be a surgery which probably will have take away both the sides.
See, it's depend. If patient is neurologically symptomatic, perilesional edema is there. But if surgery is going to cause more neurological deficit, then definitely we'll not go ahead with surgery. We'll go for surgery if means subtotal gross total dissection can be done with less of neurological deficit. Then only we'll go ahead with surgery.
Okay, fair enough. So you're saying that the neurological deficit is one thing which will obviously help you decide whether you would go for a radiation versus a surgery.
Yes, because edema will not subside immediately with radiation, but definitely with surgery it will subside and neurologically patient will be improved.
So what you're saying, it's actually the impending herniation and the symptoms which decide the next course of action. If the patient has an impending herniation or is at the life-threatening mode, you would probably anybody of us will end up preferring surgery over the radiation. However, if there is no impending herniation and you think that the patient may be able to, get away with it, or rather tolerate and not go into herniation with radiation, you would end up preferring radiation, possibly because it is also associated with less neurological deficit. Is that what the message is?
Yes.
So now coming to the radiation, the way you would want to go it, you would want to go a standard whole brain RT or SBRT. Is there a difference between the two?
We'll go ahead with SRT, stereotactic radiotherapy, rather than whole brain RT, because now the trials are coming up which have shown that whole brain RT have neurocognitive compared to SRT, and there is no difference in OS and like intracranial failure. But yes, it depends on the disease histology as well, because in some cases we prefer whole brain RT followed by SRT rather than SRT. But in this particular case, we would like to go ahead with SRT.
Fair enough. Does it matter that the patient has a hemorrhagic metastasis? Does it change anything?
Hemorrhagic metastasis.
The modality of the radiation, does it change anything? It doesn't matter, anything like that?
So hemorrhagic metastasis is aggressive. So in this case, we can treat with we can give whole brain RT also followed by SRT.
Okay. So you think because there is a risk of impending failure of that it's got a more of a, you're talking more in the sense of a prophylactic whole brain RT, or is it how does it matter? Why is it? Why would you choose a whole brain RT over SRT in hemorrhagic metastasis? That's all.
To reduce the intracranial failure.
Fair enough. I think thank you so much for taking us through it, and I think it was really helpful the way you described it.
Thank you.
I think coming back to Dr. Chandragouda, back to it. So what is the next line of therapy would you have preferred, or you prefer in such a patient now?
So I'd like to do on HER2 again and see if the patient is positive again for HER2. then TDX would be, after radiation, definitely TDX would be a right way to go. And because it's still a lot of load of the disease is too much here. So though the CPS we are sitting around 5%, single agent immunotherapy, I would not see that they may achieve a good response here with such a brain medicine. Also after RT, if a patient can be enrolled into some sort of a TDX trial, so I think I'll be, if HER2 is positive, then I'll enroll them. If HER2 comes negative, then one of the chemotherapy options can be done. So that's what I go with. Such a huge disease, I don't know whether patient would respond to immuno or not. Yeah.
So I think that's a very, very fair point. And as a matter of fact, his repeat comprehensive genomic profiling was done. And if I can have my other panelists. So when you look at so in such a patient, what would you want to look at it in the, once you are doing it and once you are repeating a NGS or a comprehensive genomic profiling? So Dr. Rushabh, is there anything particular would you want to look at it in such a, would you want to look at a TMB in such a patient? Would you want to repeat the PDL1 in such a patient, or one PDL1 is good enough for you? What would you do once you are explaining it, when you are thinking?
Dr. Bhuvan, can you repeat the question? I just missed the question.
So in a patient such as this, would you want to send a comprehensive genomic profiling now, or would you want to wait until the later?
No, so comprehensive genomic profiling for this patient who has already had HER2 3+. If I'm sending, I will send it at this point of time, but I'm not sure whether that will be helpful because patient's performance status after such a bulky disease.
No, it's pretty well maintained, by the way. It's a PS 0 to 1 patient still.
So probably if I'm going to send, I will send it at this point of time, or maybe I won't push even at this stage. Most likely, as Dr. Chandragouda said, even IO, it is unlikely that he would get that time for IO to work. So most likely, single agent chemotherapy would be something which I would offer, and TDXD if it is available and patient is still HER2 positive. For comprehensive genomic profiling, the only the basic concept would be if we get some unusual mutations like anti-RK-ALK, which is really, really rare in this situation, then we can act on it. But 28 days for report to come and whether patient's performance status would be good enough at that point of time is really something we should ponder on before sending it for NGS.
So coming back to it, as Dr. Chandragouda also said, and instead of repeating a IHC, instead of repeating a HER2 by IHC, the patient's CGP was sent, and it showed a ERBB2 or HER2 amplification with 51 copies, which was suggestive of that the patient still expressed HER2. And other than that, I think the TMB was low, and the PDL1 was 0 to 1%. It was repeat PDL1 was done, and that was 0 to 1%. And rather the TMB was 7.63 mutations per MB, per megabase, that is. So coming back to you, Dr. Chandragouda, again, so TDX is the way to go, or would you like to give a second line of second try of trastuzumab in such a patient?
No, I think trastuzumab beyond progression, there's no data suggesting that it is not going to be beneficial. So trastuzumab, big no, and it has to be a TDX. And one more point I just want to add is that it's more of a IHC based things. We also know that some sort of these amplifications in the data suggest that they may not be, if the IHC is not positive, they may not benefit from the anti-HER2 therapy. So there's data on that particular regard also. So if the HER2 is definitely positive, TDX is a way to go. So unless they have extensive lung mets because of the TDX complications, I think the TDX is a way to go.
So I think I hear you correctly. And what you said is so rightly, you highlighted the point that it is not the amplification in the comprehensive genomic profiling. It has to be HER2, and I'm more so is that because I don't think there's any trial which has found which has included patients HER2 amplification via comprehensive genomic profiling in their trials. Most of the patients, if they have done it, they have done via IHC and or by a FISH. And so I had a patient who was persistently, she was a CA breast persistently negative on IHC, and I repeated a FISH, HER2 negative. But when I sent a foundation one, it was a HER2 amplified. And I think we sat on it for at least week, 10 days. We had a discussion with the foundation team in US. And I think I took some opinion from the Mayo Clinic also, and I think they were or rather I think it was Mayo or something. They were of a pretty clear opinion that if it's not IHC, if it's not fish, I don't think you can still go ahead and add it. But however, in this patient, IHC was not done. It was he was continued on. So coming back to the Destiny trial, which showed the benefit of TDX1 in such a patient, there is a confirmed ORR of around 38%, and I think that's where it is. The patients, they end up having end up having 3 CRs and almost 27 PRs. I think so. I think we have good data for TDX now, and I think that's the way it would be. However, in this patient, just to my, I have not used a TDX. Is it available in India now? Dr. Chandragouda, have you used?
Yeah, I know it's not available. I'm part of a Destiny 06 trial. So as a part of trial, it is there. So one of my patients is running on that, though they do not get it, but it's available on a trial basis. So in a breast and stomach. So I think Dr. Vineet had this particular trial.
Okay. So he underwent radiation therapy to brain lesion, SBRT, which was a 7F3 fraction. So comprehensive genomic analysis was ERBB2 mutations. Repeat PDL1 was 0%. The patient was started on irinotecan cisplatin plus trastuzumab. So with this, Dr. Chandragouda, if the patient does not have a TDX, would you still choose to add trastuzumab, or would you like to not add trastuzumab?
And that data is enough saying that there's no point in adding trastuzumab beyond progression. So it is not going to be beneficial, one. And adding again cisplatin post platinum, again, it's not going to be beneficial. So I think it's only a single agent chemotherapy, which is probably an irinotecan has done a trick here. So not all others, I think, as per the evidence, they're not doing anything here.
Okay. So Dr. Rushabh, do you agree with that, or there's something which would you like to differ from that?
I would agree. I would have given single agent irinotecan at this point of time.
So why not ramucirumab plus iri? Why not ramu-iri together? It's also a category 1. I think it's a category 1 indication.
So we have data for ramucirumab. I had got response only in 1 patient out of 8 or 9 I have used. So I'm not a huge fan of ramucirumab. Ramucirumab, as per data, can be given in adeno second line, but I'm not a huge fan of it. And it comes with toxicity of hypertension, especially patient has hemorrhagic brain met. So that is something we should look at before giving any VEGF inhibitor.
I think the recommendation is only with the taxane. So already patient pre-exposed to taxane. Ramucirumab is a water. So I mean, as doctor,
I've had patients who have responded 2 years to ramucirumab also. It's not like that, but then, I think what Dr. Rushabh said, I would like to just add a contrapoint to it is once the patient has a hemorrhagic met, and you understand that possibly it's a there is a lot of that means there's a lot of new vessel formation, and so isn't that a VEGF inhibitor going to be act better rather than not act? I do understand where you're coming from, but then it doesn't that show that the pathology depends upon a lot of new vessel formation, and you should add a VEGF inhibitor to it.
So I think when I agree that theoretically it looks good, but I'm not sure. As all of us know that a response, if it is there, it may be there for a longer period, but number of patients responding are really low in real world practice. So again, I would say I have only 1 patient who has responded, and he responded for longer time, but all other 7, 8, it was just like water. And theoretically, it looks like it is more of neo-angiogenesis, and maybe VEGF inhibitor would work, but giving in brain mets patient, and if it is contrary, then it would be fatal for that patient. So I'm not very keen to give Ramu at this point of time in this patient. If there were no brain mets, then probably I would have added that.
Fair enough. So the patient was started on iri-cis plus trastuzumab, given for 3 cycles. There was no significant change in the chain, but there was resolution of the hepatic lesion and the number and size of lesions, and there were no new lesions. Continued on iri-cis plus trastuzumab into 3 cycles, followed by reassessment, stable disease, and continued for further 3 cycles. Now, post the 9 cycles of irinotecan cisplatin, the patient has just undergone a PET scan last week, and it's a progressive disease. So I think I'm also coming to the end of the entire thing. And if you could just, at now, what is the way forward? A patient who has had an initial CPS 5% DACO platform, the repeat, I don't think the repeat was done on a DACO platform. Repeat was done on SP263. It was done on SP142 rather. I'll just check. So, as in, a patient who has had a repeat, a repeat pedilum, initial was 5%, now 0, has kind of failed trastuzumab, and now has had a progressive disease. How do you do it, Dr. Chandragouda? What will be your take to it?
Best cost-effective way in this third line is nivolumab. We do not require CPS and all that stuff. I think Nivo would be what I would, if a patient is good PS financially and is viable, then I think that's the only option, nivolumab.
Dr. Rushabh? Hello, Dr. Rushabh? You there?
Yeah, he's there. Name is showing up. I don't know whether network area or not. Dr. Rushabh?
Thank you, Mr. So, Dr. Chandragouda, let me just ask you this. Will it be only nivolumab or nivolumab plus chemotherapy?
Only nivolumab in the third line.
Okay. And you still not a fan of ramucirumab plus taxane?
No, never. Yeah.
And, would you want to try a FAM deruxtecan now?
If HER2 positive, then definitely. I mean, I was talking the second line as well. So if HER2 is persistently positive, then yes, FAM deruxtecan, I think trastuzumab should be explored.
Dr. Shefali, now because you've heard the entire story, what will be your take on the story?
So, I mean, I would agree with whatever is there. Trastuzumab deruxtecan is not available. If available, it would be the choice. If not used, still, again, I also re-insist, I'm not a big fan of ramucirumab. Hardly, I mean, countable patient have responded rather than all. So nivolumab, I think in the third line is the way forward. Because I mean, you can give it in performance status 3 patients even, if the patient is willing and understanding whatever benefit we can have. So I think beyond that, if I don't think that performance status ever permits beyond third line in stomach, but if he's lucky enough, so maybe another metronomic type of therapy would be my choice, or best supportive care. I think that is all.
Fair enough. So I think possibly that for me the thing is still open, and we'll see when the patient comes and we'll tell everybody. But then this patient,
yeah,
let's see, we'll have a discussion with them. Anyway, that's from my side, and thank you, thanks a lot, Dr. Shefali and Dr. Nikhil. I think he's not there. You both are doing such a fab job of it. I think the way you have this GI series going on, I think it's really, really amazing. So I congratulate both of you for I think this is the 22nd episode, 23rd episode. How many is this?
Yeah, 22nd. So we'll be celebrating 25th with some new ideas. I don't know, still planning to, but it's wonderful. We have got wonderful responses, really good discussion, purely on academic basis. So that is the beauty of it. So, and I really thank all of you for contributing and participating. I know 8 o'clock, 8:30, sometimes it goes up to 9 also. So it's wonderful to have this good discussion always. And before just concluding, we'll take 2-3 questions which are there. So Dr. Chandragouda, I think you can answer that. So Dr. Nirmal has asked if we start immuno plus trastuzumab in first line along with chemo in HER2 positive cases and patient progresses. So is there a data that we use immunotherapy in subsequent lines if we retest PD-L1, and how is the way to
No, big no. I have already told, personally, I answered him also. There's no, you cannot do that. Yeah.
Right. And I think all other questions have been answered. There is no such further question. All right. So if there is no question, so I thank you all for joining, contributing your time. Thank you. Thank you once again.
Thank
Good
you.
night.
Thank you. Okay, bye.